All right. Welcome to Identifying Red Flags in Patients with an Eating Disorder. My name is Lydia Rhino, and I am the Program Director here at the Eating Disorder Foundation. And I am excited to welcome everyone here this morning, joining us wherever you're at. Here in Denver, it's still the morning, so that's what I like to say. Today's workshop is brought to you in collaboration with ACUTE Center for Eating Disorders and Severe Malnutrition at Denver Health, along with us here at the Eating Disorder Foundation. I'm going to take a moment to share a little bit about the Eating Disorder Foundation. We are a nonprofit that was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver-based organization that is now serving individuals and families both nationally and internationally. I want to thank anyone who made a donation upon registration. We're able to provide free services because of the generosity of our community. I'm going to add the donation link in the chat if you wish to contribute. If you have any questions for our presenter, I invite you to use the chat feature to communicate with me directly throughout the workshop. The chat is kept confidential and will come to me directly. I don't share anyone's names associated with questions being asked, so please feel free to send me those in the chat. And we'll hopefully have some time at the end for Q&A after the presentation, but if there's not time, we'll make sure to follow up with any questions that haven't been answered. We will not be sharing the PowerPoint. However, we are recording this morning, and we'll send out the recording as soon as possible. And now I am so happy to introduce Dr. Kamila Cass. Dr. Kamila Cass is a clinical psychologist at ACUTE Center for Eating Disorders at Denver Health, providing psychodiagnostic assessment, individual and group psychotherapy, and crisis intervention services to individuals with severe eating and feeding disorders.
Well, thank you so much, Lydia. I really
Of
appreciate
course.
it. It's really an honor to be here today talking to you all, and I hope that this talk is informative. Feel free to save any questions for the end. I'd be happy to answer them. And thank you also to the Eating Disorder Foundation. It's really wonderful to be able to help out in this field in this way. So today I'm going to be talking about red flags in patients with eating disorders. I'd like to state that I have no conflict of interest. And I am an acute psychologist. I've been working here at Acute for about 7 years. Acute is a 30-bed dedicated medical stabilization unit here in Denver. And we are all gender inclusive, ages 15 and up. We provide 24-hour patient observation. Most of our patients with very severe eating disorders arrive via air ambulance. And all the staff here are dedicated to treating those with severe eating disorders and malnutrition. And many are credentialed and have their SEDS. We are in network with most insurance companies, and we provide room-based care in a private patient setting. It's really a joy to work at Acute because it's a multidisciplinary environment. We not only have therapists and medical doctors, we have psychiatrists. We also have people in rehab, so physical therapy, occupational therapy. We have nurses, a social work team. So people really do get comprehensive treatment here. So the learning objectives for this talk are to identify 5 common eating disorders, relate their diagnostic criteria, and highlight the medical and behavioral red flags that might indicate that this person has an eating disorder, may need a higher level of care if they're already in treatment for an eating disorder, or help you provide education about any eating disorder behaviors. Another learning objective is to explore medical complications that indicate that your client may have a serious eating disorder and may need a higher level of care, and to understand the levels of care in eating disorder treatment, including options for treating individuals with life-saving eating disorders. When I started in this field over 20 years ago, I did not know that there were levels of care for the treatment of eating disorders. And so I think it's so important just to know that there is a system of care for treating these illnesses because the risk of death is so high and because eating disorders really impact the physical body so much. So what causes eating disorders? Highly multifactorial. There is definitely an element where biology and genetics plays a role, especially in anorexia nervosa. Females with a relative who has anorexia nervosa are 11 times more likely to develop the disease themselves. Other factors include social, interpersonal, and cultural factors. This is where things like body dissatisfaction, the thin ideal come from. Sort of the body image that is idealized is prescribed by culture and society. And so this plays a major role in creating feelings of body dissatisfaction, which are a risk factor for the development of an eating disorder. And then there are psychological and behavioral patterns and experiences that can sort of contribute to an eating disorder. For example, in anorexia nervosa, people who are very perfectionistic, harm avoidant, rigid, these kinds of personality traits kind of lend themselves to anorexia nervosa. People who have experienced significant trauma may turn to eating disordered behaviors to escape, to cope. And then also the behavior of dieting is sort of a direct pathway to develop an eating disorder. So very multifactorial when we're thinking about it. These are the eating disorders we're going to talk about today. And this is a list of all the possible eating disorder behaviors, or at least the most common ones you will see. So you will see restriction in eating disorders, whether through dieting, whether through orthorexic sort of beliefs and eating patterns, people who may be fasting or doing, intermittent fasting, that may be sort of a cover for restricting. Another behavior is binge eating. That's where a person eats a very large amount of food in a short period of time and feels a loss of control. This is something that you see in several eating disorders. There's also compensatory behaviors. This is engaging in a behavior to undo eating or calories. And examples of these would be self-induced vomiting, laxative abuse, diuretic abuse. There's also the misuse of insulin in folks with type 1 diabetes. It actually has the highest death rate of anybody with an eating disorder. If they have type 1 diabetes and they're abusing their insulin, the risk of death is very high. So we'll talk about that in a little bit. Exercise, while it's really good for the body, movement's a good thing. Over-exercise, compulsive exercise are things that are seen in eating disorders. And then more recently, GLP-1 misuse is something that we're seeing more. These are the different eating disorders, and we'll go into depth into each of them. But just to notice that the main symptoms, again, that you will see are restricting, purging, body dissatisfaction, weight suppression or being underweight, and then binge eating. And on the left, we can see the different eating disorders there, and they are defined by what symptoms are present. So in anorexia nervosa, you will always have underweight be present. Sometimes you will have purging being present, other times you won't. And that's sort of how the diagnosis is made, is on what specific symptoms are there. So as we talk about red flags, one thing to notice is that eating disorders can be tricky. People with normal labs and normal body weight may be struggling with eating disorder issues. It's often hard to diagnose because eating disorders are both a medical and a psychiatric illness. Eating disorders are usually pretty ego-dystonic, or actually ego-syntonic, I mean to say. That means that the eating disorder is something, especially in cases of anorexia nervosa, that a person feels as their identity, or it's what they're good at, or it's what they use to cope. And so there is usually some ambivalence about entering recovery or being open about what's going on in their lives. And those who have an eating disorder, the longer it goes on, it can be harder to treat. At least it become more deadly. So definitely early prognosis, early identification, these are very important. Eating disorders like anorexia nervosa in particular have the highest mortality rate except for opioid use overdoses. So it is definitely a deadly disorder and should be taken very seriously. And eating disorders thrive in secrecy, and patients can often be resistant to interventions, as I mentioned. So when you think about eating disorders and who to look for eating disorders in, think about everyone. Eating disorders do not discriminate based on anything. It affects all genders, all socioeconomic statuses. all cultures, all races. And here are the things that you really want to look at if a person is reporting low heart rate, low blood sugar, low potassium, if they're showing rapid weight loss, if they're fainting in an otherwise healthy person, or if they experience amenorrhea. These are major red flags for an eating disorder. So definitely being aware of these. So the first illness we'll talk about today is anorexia nervosa. And anorexia nervosa has been around since the Middle Ages, and really, has increased in frequency since there's been sort of this thin ideal that's spread throughout the world, this or idealized body shape where thinness is viewed as something that is, what you want, especially as a woman. And so this eating disorder is definitely out there and it's very deadly. It also occurs in men, about 1 in 10 males. I think it's a 1 in 10, let's see. I think for those who are hospitalized, about 4 to 5% are males, I'll put it that way. So anorexia nervosa, you're getting a restriction of energy intake relative to requirements, leading to significantly low body weight. So often at acute, we see people with BMIs of 12, 11, 10 at times. There is an intense fear of gaining weight or a persistent behavior that interferes with weight gain, even though a person is at a significantly low weight. So this persistence of the low weight, despite them knowing that it's bad for them, that's one of the key diagnostic criteria. Anorexia nervosa also has an overvaluation of weight and shape, where people really place their value on their body shape and often just lack insight into how serious their condition is. They can't appreciate that they could die from the illness or that they may need to go to a higher level of care. Anorexia nervosa, there's 2 subtypes, A and R, which is restricting anorexia nervosa, involving restriction of calories and overexercise at times. And then there's a binge purge form of anorexia nervosa, where a person engages in restriction and then a compensatory behavior, such as vomiting, abuse of laxatives or diuretics, and they may engage in binge eating, but they may not. So what are some red flags to look for anorexia nervosa? So if you have a client and you're noticing that over the weeks of working with them, they have a pretty severe weight loss, a rapid weight loss, that's a red flag. If you have a loved one and they talk about skipping meals, or you notice that they delay their eating throughout most of the day, that is a red flag for anorexia nervosa. Almost everybody who has the illness does 3 things. They delay their eating, they restrict their eating to mostly low-fat foods, and they engage in rituals around eating. So these are some of the red flags to look for. Also look for increased exercise, obsession with weighing, calorie counting. I know in the zeitgeist right now, wellness is a really kind of an it thing, but wellness can also be sort of a cover for anorexia nervosa, especially if somebody's really adopting a lot of orthorexic beliefs and they talk about trying to eat super clean. That can go to an extreme and can turn into anorexia nervosa. What you'll also hear from people with this illness is a fear of weight gain. And you may notice that people avoid activities, they avoid eating dinner with their family, they avoid going to gatherings where there's food, and just a certain level of isolation increases. So I'm not a medical doctor, but there are numerous medical complications of malnutrition. Every system of the body is impacted by malnourishment. And so the good news is that when a person gets treatment for anorexia nervosa, everything can improve except for low bone density, because once you lose the density of the bones, that's kind of gone. You can only arrest bone loss. And then if there is Wernicke's encephalopathy that has occurred due to low sodium or repletion of sodium too fast, that is permanent. And so it can result in permanent brain damage. Here are some other red flags that you might see in a person that would indicate that they might need to be screened for anorexia nervosa, that they might need to really get some help. So the first one is temporal wasting. So wasting around the cheekbone of the fat that's inside the face. As anorexia nervosa entails significant weight loss, all the body utilizes all of the fat that's in the body, taking it from the insides of the body and from the outsides. And so you'll see kind of these very sharp cheekbones. Something else that you'll see, whoops, let me just go back, is lanugo, and this is a fine layer of baby hair that's sort of peach colored that will grow on the face and the arms, and it's an attempt of the body to keep itself warm in a malnourished state. It doesn't happen in people who are at normal weight. Acroceniosis is where, due to lack of circulation, people's extremities, like their toes, turn blue. This is something that we see at acute quite a lot. You'll also see leg swelling or edema due to electrolyte abnormalities. People can put on a great deal of water weight in a short amount of time. For example, if they cut out laxatives, if they stop their abuse of laxatives, they can gain sometimes 20 pounds in a couple days, which is very distressing, leading people to go back to the laxatives. And so edema can be a symptom, a red flag of anorexia nervosa. Brittle nails, because the body is not getting the nutrients that it needs. It's actually in a very severe deficit of protein. And then thinning hair and dry skin. I know at acute, we've seen young people come in having lost most of their hair due to the malnourished state. The good news is that that comes back, and by the time they leave here, they have a pretty nice sort of buzz cut going on. So again, there's a lot of hope for anorexia nervosa when treatment is sought. So some non-specific cardiovascular symptoms that you'll see in anorexia nervosa would be fatigue, heart palpitations, a very low pulse or a very high pulse, that's called tachycardia, regular fainting or passing out, shortness of breath, inability to exercise anymore. The folks that we see here at acute, often they're airlifted here and they're not able to even get out of bed or lift their head up because they're so malnourished and deconditioned. People are often extremely cold, and there's also really a decrease in mood. So depression and weight loss into malnourishment go hand in hand. And so the more a person loses weight in an unhealthy way and enters malnourishment, the higher their depression and anxiety will be. And that's because they're not able to have their neurotransmitters function normally because they are produced in the gut, and that takes nutrition to produce our neurotransmitters. And so you'll see people entering a depressed state. Oftentimes they will feel full very quickly after a meal, and that's due to the changes that occur in the digestive system due to starvation, where everything slows down. And so even if a person is trying to gain weight, they often can't gain enough weight on their own because they can't tolerate the fullness that comes after just a few bites. So something to be aware of with anorexia nervosa that contributes to why it's such a high death rate is refeeding syndrome. And this was discovered after World War II when people who had been in a malnourished state were given large quantities of food, of carbohydrates. Many of them ended up dying. And this is because in starvation, carbohydrates are really depleted from the body. And so the body is using fats and proteins to convert them into energy. But then when you refeed somebody and give them carbohydrates, it's a sudden shift of their metabolism, which can cause extreme electrolyte imbalances. And they can have all these conditions develop, like hypophosphatemia, hypokalemia, which can lead to death, cardiac stoppage, and renal failure. So if somebody is very low weighted and they say, oh, I'm going to just try to eat on my own and get back, they really should be seeing a professional and getting evaluated medically, because they may be at risk of dying from refeeding syndrome should they begin to bring more calories into their body. Another medical condition to be aware of in anorexia nervosa that is deadly is low blood sugar. So as a person enters into a malnourished state, they really deplete their liver and their muscles of glycogen stores, and their body is at very high risk for low blood sugar. And so their blood sugar just gets lower and lower and lower. And it's particularly dangerous at night when they're sleeping. And so oftentimes, people can die in their sleep. And so the treatment for that is nutrition. And we often have to have people on feeding tubes because it gives them a consistent rate of nutrition and keeps their blood sugar steady. Arrhythmias are also something that can be very deadly in anorexia nervosa. So bradycardia is the most concerning. That's low heart rate. And so a person's heart rate may just go lower and lower and lower as metabolism slows down further and further. And it's the most frequent presenting sign of anorexia nervosa. And this is also where people can pass in their sleep because their heart just gets slower and slower. And so again, the treatment for this is nutrition. And then the last medical issue to really know about for anorexia nervosa is SMA syndrome, which is called superior mesenteric artery syndrome. This is where the body, using all the available fat from the insides of the body, will use a fat pad that separates the aorta from the superior mesenteric artery. And so they begin to sort of touch each other and creates a lot of pain when a person is eating. And so that will further entrench the malnourished state because they try to eat, they experience pain that is real, and so they stop eating. And so this is why knowing what levels of care is so important, because often people with SMA syndrome need a feeding tube or a liquid diet because it's so painful. But the good news, again, is that as they renourish, the fat pad will grow back and then they will not be in pain when they eat. So here's a criteria for medical hospitalization for anorexia and ARFID. A weight less than 70% of their expected ideal body weight or expected body weight. Unstable vital signs, so a pulse under 40 or even under 50 is high risk. Arrhythmias, signs of liver failure or hypoglycemia, that's low blood sugar. Significant abdominal pain or heart failure. Failure to restore weight in another setting. So a person is saying, I'm going to gain weight and do it on my own, and they're not. That's really a sign they need a higher level of care. And sometimes they need to be stepped up here from residential or partial hospitalization because their behaviors are too hard for them to control. And maybe they're purging, maybe they're restricting, and they just need the 24/7 monitoring that ACUTE provides. So this is one of the most important slides in this talk. This is a slide about the levels of care of eating disorders. And again, when I first started in this field, I didn't know that the treatment was so specific and that it entailed a very long course of treatment, honestly. So think about treating an eating disorder as a person climbing over a long mountain range. There's a number of mountains that they have to scale, and it can take some time before they can really be free of the eating disorder. So starting with this kind of blue mountain, the biggest mountain would be medical stabilization. Not everybody has to start at this level, but that is for people for whom their ideal body weight is, they're less than 70% of their ideal body weight. They have medical complications that are endangering their life. They would need to start out at this level of care that takes medical insurance. So we don't take, behavioral insurance. We actually work off the medical model, and it's like being hospitalized in an intensive care unit. The next level of care would be inpatient specialized. Sometimes that's combined with what's called residential treatment. These are 24/7 facilities as well, but with less medical oversight, but where a person is being monitored, all of their meals are being observed. Bathrooms are locked so that they aren't able to engage in purging, and it just provides a person a lot of support to begin to move beyond the habit of their eating disorder. And once they are feeling more confident in their ability to ignore the eating disorder voice and to stop purging or stop restricting, then they're ready to transfer down to partial hospitalization. And that is 7 days a week for most of the day, but they would be sleeping in their own home or maybe in an apartment near the facility. And this is where they learn more skills about helping themselves overcome eating disorder urges. They learn more coping skills in general. After they've completed that, they would step down to intensive outpatient. That would be about 9 hours a week, or 3 to 5 days for a couple hours each, where they'd have a shared meal and they would participate in groups, but then they would be on their own for a large percentage of the day, making sure that they can remain free from their eating disorder behaviors. And then lastly and finally would be outpatient. And that would be having a therapist, a dietitian, a PCP, perhaps a psychiatrist, and meeting with them weekly for at least a year. So that would be the levels of care. And here's the general weight guidelines for levels of care. So again, medical stabilization would be for those less than 70% of their ideal body weight. And then inpatient residential, generally above 65% of their ideal body weight. Residential would be above 70% of their ideal body weight. Partial hospitalization would be above 80% of their ideal body weight. Intensive outpatient above 85%, and then outpatient above 85%. And the closer a person can get to 100% of their ideal body weight, the less likely they are to relapse. And so weight gain is a very important thing in the treatment of eating disorders in terms of preventing a person going back. If you are more curious about the treatment guidelines for eating disorders, the American Psychiatric Association has clinical practice guidelines, as does the Society of Adolescent Medicine, and then also something called the RED-C, which is the Residential Eating Disorder Consortium. Okay, next eating disorder we're going to talk about is called atypical anorexia nervosa. This is in the category known as an other specified feeding or eating disorder, OSFED. And this is where a person has all of the criteria for anorexia nervosa, except that despite significant weight loss, their weight is still within or above a normal range. So they still have a drive for thinness, a fear of weight gain, an overvaluation of weight or shape. They've experienced significant weight loss in an unhealthy manner, except they're not yet sick enough to see it, in a sense, visibly in their body. So they will look to be at a normal weight or to even be above a normal range. But don't let it fool you. They still have anorexia. It's just labeled atypical anorexia nervosa. And they experience many of the same physiological complications as those with anorexia nervosa. So we think that the base rate of anorexia nervosa that's atypical is actually quite high, maybe up to 4% of women. And this is because of weight stigma and because this often goes untreated and undiagnosed. So, how I mentioned that dieting is really can be a trigger for developing an eating disorder. We know that even a 5% weight loss from a natural body weight state combined with cognitive concerns can lead a person into having an eating disorder. And those with atypical anorexia nervosa have usually a similar or longer duration of the illness and the same intensity of behaviors. So they're restricting just as much. Maybe they're using laxatives just as much as those with anorexia nervosa that is typical. They may even have higher levels of psychological symptoms like depression and anxiety, and have typically experienced having their symptoms trivialized or dismissed. Well, you're not underweight, so, even though you've lost weight, maybe that's, it's good for you or things like that. So it's really something to know about and to ask your clients about if they talk about body dissatisfaction. What are the behavioral red flags for atypical anorexia nervosa? Same thing for typical anorexia nervosa. You're going to see this severe and rapid weight loss, people going out of their way to not eat. You'll again see the major symptoms of skipping meals, delaying eating until way late in the day, and eating mostly low-fat foods or deleting whole food groups. You may see increased exercise. You may hear verbalizations of feeling undeserving of eating, vocalizations of a fear of weight gain, and then the increased isolation that an eating disorder brings. So people avoiding eating with their families, going out to dinner, activities that involve eating. So in terms of the medical complications of atypical anorexia nervosa, there's really limited research about this, but it appears to be about the same as those with typical anorexia nervosa. Because weight loss that is rapid and done in a very unhealthy manner creates the same complications in the body. So it will create the low heart rate, it will create the low blood sugar, and all of these can be deadly. So it's important to keep that in mind. Okay, we're going to move to bulimia nervosa now. Bulimia nervosa is an eating disorder that's characterized by recurrent episodes of binge eating. And that is really defined by eating 2 or more large plates of food within a 2-hour period, accompanied by a loss of control. The person will engage in binge eating, and then it will be followed by compensatory behaviors to undo the eating or calories, like self-induced vomiting, misuse of laxatives, diuretics, or other medications, or fasting. And they also have body dissatisfaction or an overvaluation of their weight or shape. Laxatives is something that is really to be taken very seriously. Laxatives are in many ways addicting, and they do bring out feelings of tolerance. So a person has to take more and more laxatives to get the same effect. And laxatives are highly deadly. So the second most common sort of symptom profile of somebody who dies from an eating disorder is somebody who's abusing laxatives. So first would be somebody who has an eating disorder plus diabetes type 1 and is misusing their insulin. That would be followed by people who abuse laxatives. Okay. And there's severity specifiers for bulimia nervosa: mild, moderate, severe, and extreme. And these are based on the number of binge and purge episodes. Here at ACUTE, we do treat individuals with bulimia nervosa. Some people are just unable to stop themselves from purging. It almost goes on automatic pilot, and they purge sometimes up to 30 or 40 times in a day. And they really need to come to a setting where they are completely monitored and have no ability to do that. All right, so what are some red flags for purging behaviors? If you notice large amounts of food disappearing quickly, so one day the refrigerator has a lot of food in it, and the next day a lot of the food is gone, that's really a sign of binge eating. If you see wrappers around, people being in the room a lot, they may be engaging in binge eating secretively. This is especially common among children. For bulimia nervosa, using the bathroom immediately after eating, which is where they would go probably to purge, that's a big red flag. If you see packages or packaging from laxatives or diuretics, that's another red flag. Dental issues is something that results from purging, and that's a big red flag, as is something called Russell's sign, which I'll show you a picture of in a minute. And then fluctuations in weight. So people with bulimia nervosa can up and down very rapidly. If they're abusing diuretics, their body's depleted of water, they lose a lot of weight, and then they will usually get edema on the way back up from that. And they may also experience fatigue, dizziness, and fainting as a result of the electrolyte abnormalities that are happening. So here are some of those red flags to look out for. So enlargement of the salivary glands can occur when a person who is a regular purger, when they stop purging. So the parts of the face will really swell up almost, I think that people have made mention of sort of chipmunk cheeks in the past, but you will see these salivary glands getting really swollen for a time. And so that's a sign that somebody is purging. You will also see dental caries or cavities. And on the back side of the teeth, you'll see erosion from the enamel erosion, and that's from the acid from throwing up. Russell's sign is something to look for on people's fingers, because if a person is using their fingers to self-induce vomiting, often their finger will scrape against the back of their teeth as they're pulling their hand back, and they'll have sort of these sores or kind of scars on their hand. Other times, a person could be engaging in self-induced vomiting and you wouldn't see Russell's sign. It's over time, people develop the ability to purge without using their hand. They can purge by just thinking about it or by pressing on their stomach. And people with bulimia nervosa or anorexia nervosa binge purge subtype who are trying to really hide that they are self-inducing vomiting, they may know that others will look for a Russell sign, and so they'll be using a spoon or something else like that. So just to know about that's important. And then the last sort of red flag you might see is ruptured blood vessels in the eye, and that's from purging. There are many complications from purging. Here's a list. Again, it affects many systems of the body and can even cause, in a sense, sort of what's called cathartic colon, which is like a death of the colon. And so it's very important that a person who is abusing laxatives, is engaging in self-induced vomiting, that they really are in the right level of care to address their medical conditions that may be there and to help them be able to stop. Okay. Something else to know about bulimia nervosa and anorexia nervosa binge purge subtype is that, again, with cessation of purging behaviors, a person may experience a rapid amount of water weight that comes into their body. And it may develop into something called pseudo-Bartter syndrome. And if occurs, a person definitely needs to be hospitalized because they can have real problems with their heart because it's really surrounded by too much water. And so getting off of laxatives, again, is very difficult for people. And usually they can't do it on their own. They need to come to a setting where they can't have access to them and have time for the habit strength of laxative use to decrease. Purging also affects the electrolytes, which again can be deadly. This is why those who engage in purging have a higher mortality rate than those who, for example, engage in restricting only. And so self-induced laxative use and diuretic use can really alter the potassium and sodium and acid base in the body. So medical monitoring is very much indicated. Criteria for medical hospitalization for bulimia nervosa or anorexia nervosa binge purge or atypical anorexia nervosa that has binging and purging would be a potassium less than 2.8, a bicarbonate that's higher than 37, prolonged QTC, that's sort of a heart rate interval, excessive edema or history of edema with cessation of purging behaviors, and consistent and heavy use of purging behaviors or any of the conditions we spoke about prior. So I've worked in a number of different settings as an eating disorder specialist. And when I worked in outpatient settings, I would attempt to work with people who were engaging in purging behaviors and see if outpatient therapy was enough to help them be able to stop. And I will say often it was not enough. And I had to refer patients to higher levels of care because the purging behavior can be so habitual that a person just will do it automatically and will do it without thinking. And so they really need the help of a place that can make it impossible for them to engage in that behavior. So that's why, again, this is the most important slide in this presentation, is just understanding that with eating disorders, you want to make sure that the person is going to the right level of care. And so it may be that they need medical stabilization, or maybe they're working in an outpatient basis and their purging is happening so frequently, you need to step them up to partial hospitalization where that's very helpful. But if it's not helpful, they might need to step up to residential treatment. And so it's really about finding the right level of support that matches the difficulty of stopping the symptoms. Okay, we'll talk briefly about binge eating disorder. This is actually the most common eating disorder in America. Often goes undiagnosed, but its symptoms are recurrent episodes of binge eating, plus the feeling of losing control or a feeling of sort of regret about binge eating. And it's accompanied by feelings of guilt, feeling disgusted with oneself, feeling depressed about eating, just feeling really out of control, eating large amounts of food when not feeling physically hungry. And there's just marked distress and feelings of shame about binge eating. And so when I've worked with people with binge eating disorder, really having them even be able to talk about it and giving it a name and unshaming it and normalizing it in terms of how common it is, all of these things can be really helpful. People who engage in binge eating disorder don't engage in self-induced vomiting or overexercise or restriction. So it's safer in that sense, but it's still very distressing. And so having a person get the right treatment can really be a benefit in their life and can help them stop binge eating. So behavior red flags is just to know that it often goes undiagnosed. And what you'd be looking for would be unexplained disappearances of food, elevated level of body image concerns, distress about binge eating, feelings of depression, and in some cases, a person may engage in dietary restraint. For example, they may delay eating through the morning because they're very full from a binge from last night. Um, and so you may see that, but it's still not bulimia nervosa because they're not engaging in these very overt and extreme compensatory behaviors like self-induced vomiting, laxative abuse, or diuretic abuse. So the major medical complication of binge eating disorder would be a higher propensity to develop type 2 diabetes and insulin resistance, and then to have kind of the sequelae that occur from the overweight state, which could be obstructive sleep apnea, metabolic syndrome. So you'll be looking at sort of additional chronic conditions among those with binge eating disorder. The good news is that this is very treatable, and cognitive behavioral therapy for binge eating disorder is extremely effective. Our last eating disorder to talk about today in terms of what to look for would be something called avoidant restrictive food intake disorder. This is new as of 2016, and when I started in this field, this did not exist. It was only really voiced and looked at for children, but this is something we know that occurs in adults and really can be functionally impairing. So this disorder is called ARFID. We sort of shorten it to the word ARFID. And what it is a disorder where a person loses a great deal of weight and they enter into a malnourished state and they become weak and they have these other health conditions you see from malnourishment. But it is not due to them wanting to lose weight, trying to lose weight, feeling body dissatisfaction, wanting to be super thin. It doesn't come from that at all. Rather, it comes from them not eating enough food for psychological reasons. And here are the 3 reasons why this can develop. A person can have one of these up to 3 of these all at once. The most common form of this that we see on our unit here is what's called fear of aversive consequences. And this is where a person stops eating enough food because they've had a bad experience with eating. So maybe they had a really bad bout of a intestinal bug and they were throwing up and throwing up. And just the sight of food makes them feel like they're going to vomit. And so they just start to avoid food. And then what happens over time is that the more they avoid the food, the more afraid of the food they become. So let's say they've had an experience of choking when they eat. They avoid food because they're afraid of choking. And the more they avoid that, the greater the fear is. And so the fear will grow and grow and grow because they're avoiding it. And that's a safety behavior that does not allow them to test their fear and find out for themselves that they can actually eat without vomiting or choking. So a person gets locked into this sort of cycle of eating less and less and less in this fear of aversive consequences. And it can really lead to dire medical conditions. So at ACUTE, we have a dedicated track for those who have ARFID where they receive personalized treatment, because what happens is that people are accused of having anorexia nervosa, or people are sort of saying, why can't you just eat? What's your problem? And so the validation of knowing that this is an actual feeding disorder and it does exist and there's good treatment, that can be very helpful and healing for people. The other 2 causes of ARFID would be if a person just lacks an interest in eating. Maybe they're depressed and they just lose their appetite. And over time, their GI system will slow down because it's not getting enough nutrition. And so they're getting gastroparesis, which is a slowing down of the GI system. So they have less hunger cues. They feel full faster. And this can create a person entering into a malnourished state. And then the other reason would be if somebody has sensory-based avoidance. So if the smells of certain foods or taste or texture of foods is very unpleasant for people, they will limit the variety of foods that they eat. And when you limit variety, you end up limiting calories, and taken to an extreme, a person can lose a lot of weight. So again, we see all three of these on the unit, but mostly it's where a person is afraid to eat because they're afraid of feeling pain in their stomach or of choking. So here are the red flags for ARFID. You're looking at weight loss, eating less over time, or delaying eating, kind of similar to what you would see with anorexia nervosa. You would be seeing avoidance of certain foods or foods in general. So when children have ARFID, sometimes they will only eat foods that are a certain color. Sometimes they will avoid all vegetables and fruits. And so it really can be very particular to the person. And people might avoid eating due to the fear of throwing up or pain, again, or to the lack of interest in eating, or experiencing increased pain when they're trying to eat. And then this leads them to have isolation and avoidance and blame themselves. And so if you see this, if you spot this, letting a person know that this can be treated and may need to be treated at a high level of care can be honestly just such a relief for a person to find out. What are the medical complications of ARFID? Very similar to malnutrition and restrictive eating disorders. It should be noted that people can also engage in purging behaviors in ARFID, but it's not to lose weight or undo eating or calories. It's for the purpose of trying to not feel so full and trying to get rid of the pain. And so if somebody eats and they have pain in their stomach, they may make themselves vomit because that releases or reduces the pain. But you have to make the diagnosis very carefully to make sure it's not hiding out, it's anorexia nervosa, but that can actually happen in ARFID that a person is purging. But again, it's coming from, what are their motivations for the purging? Okay, so other general red flags that you might see that would lead a person to question if somebody has an eating disorder would be frequent medical office visits. So emergency room utilization. Our patients have usually been in the ER many times before they come and eventually stay with us. Frequent primary care visits and specialist visits. So oftentimes GI visits, and then dental visits. So dentists are often the first to spot an eating disorder. So in terms of the ER, people go to the ER oftentimes because of their eating disorder symptoms, because they're dizzy, because they fainted. And so it's something to be really aware of. Almost 20% of adolescent emergency room visits are eating disorder related. So again, where a person will really get help can vary, and it's not always in a therapist's office. It's sometimes first spotted in the ER. In primary care visits, we see a lot of eating disorders. So 50% of eating disorder cases were first diagnosed during a primary care visit. And so the importance of primary care doctors understanding how common eating disorders are and that they really can ask, and there's no harm in asking, that's really important. And so people with eating disorders do have contact with others, but only 28% seem to actually get assessed for eating disorders. And it's likely due to people not being open about having an eating disorder, or practitioners not asking or not noticing or not realizing they could have one. So that's why understanding these red flags are so important. And I thought I would just briefly mention, in terms of working with people with eating disorders, especially anorexia nervosa, because it is egosyntonic, it tends to, treatment tends to be something that people maybe don't feel so jazzed about, and they don't really want to go to treatment. And so what can parents and loved ones do to help their child, adult child, their spouse get into treatment? It is important to know that in Colorado, we do have unique laws that recognize that anorexia nervosa can render a person gravely disabled, meaning that they are unable to care for their basic needs, including nutrition, and they're at risk of dying. And so we do have the ability here at ACUTE to mandate care. We use this very judiciously and case by case. It's very, very considered, but when we do, it's viewed as a life-saving intervention. So if somebody comes to us and they have a glucose of 20 and they are not, and they're refusing food and they're refusing glucose tabs and they're refusing a feeding tube, we do have the ability to put them on a mental health hold and then later a short-term certification, which mandates them to care in the state of Colorado for up to 90 days, but it allows them that life-saving intervention of getting that glucose that they need. So we use this sparingly, but it is something that does save lives. Other resources for learning more about eating disorders would be the Academy of Eating Disorders, the American Psychological Association, the Eating Disorder Foundation, the Alliance for Eating Disorders, and others out there. What is a prognosis for eating disorders? It's actually, I do feel it's important to relate a very hopeful prognosis. I think people have learned over the years that it's, oh, there's no help for so-and-so, they have anorexia nervosa, but really most people with eating disorders recover. It can take a long time. So in anorexia nervosa, it can take up to 22 years. But by that time, 62% of people, or actually 68% of people have recovered from anorexia nervosa. Some people experience sort of partial recovery, a waxing and waning course. We do see a lot of readmissions. Again, it's kind of the nature of the illness until full recovery is finally attained. There is a high mortality rate. Again, the highest is in what's called diabulimia, or when somebody has an eating disorder plus type 1 diabetes and they abuse insulin. Anorexia, using laxatives would be the highest, next highest, then anorexia nervosa, then binge, then bulimia nervosa, and then finally binge eating disorder is the lowest risk. And eating disorders have a duration average of 7 years. Please call us at ACUTE if you have any questions. We are happy to direct you to what care is available, what level of care might be needed. And then I will turn it over to Renee Hartman, our provider relationship manager, to close it out.
Thank you. Great job, Kamila. Actually, Lydia, were you going to field those questions? I'll let you go ahead and take charge on that. Awesome.
Beautiful.
Thank you.
Sounds good. Awesome. I love this presentation. Thank you both so much. We got some questions, so I'm really excited to hear responses on these. With our first question, we are going to refer back to kind of near the beginning of the presentation around bone density. Someone in our community here has done some research on being able to heal, repair bone density. So someone is wondering about medications to build bone density and weight-bearing exercises. They've seen some research that shows that DEXA scans can show improvement in bone density with better nourishment along with weight-bearing exercise. So I wanted to hear your reflections on that and if you have any input on that topic.
I think they are absolutely right. I mean, I think what we were taught always was that you can just arrest bone development, but I think some of the new research is showing that it's very hopeful when you can build some of the bone back. And so definitely medications. I'm not a medical doctor again, so there are medications out there that help with that. And we at times do have our patients on those medications. And then, of course, weight-bearing exercise is so important. I go to the gym and I lift weights and there's people probably aged 80 in the groups, and it's so beneficial at any age and so helpful for the bone. So thank you for that clarification. Great point.
I always figure that, especially as work advances in this field, that there's going to be new things that come out and that are oh, cool. It's always helpful just to know that there has been changes and things. So helpful to just reflect on. Next question is IBW versus BMI. This person sees more residential treatment centers looking at BMI as criteria. Should they focus more on IBW rather than BMI?
That's a great point. Here at ACUTE, we do go by IBW, not BMI. And the reason is because BMI can be Overinflated, especially in males. And so a male could have a way too low body weight, but the BMI would mask it, would show them at a higher BMI than it would be seen if you calculated for ideal body weight. None of these are perfect. I think the field is still looking for a kind of an even more personalized and individualized way to determine when a body weight, but BMI, because it's sort of a blunt number, it's looking at just a few calculations, we found that it's especially not appropriate for men, and then it tends to not be that. I think it even overinflates it somewhat for women. And so IBW is more precise, and that's what we use. Expected body weight, or NBW, normal body weight. I think the field is trying to figure out how even to call it.
Very helpful to hear. And I know that BMI has been a topic of conversation throughout the field for a while too. So I'm always curious to hear what clinicians think when they hear those kind of questions. All right, next question is, I've had a few patients who began restricting after doing a food sensitivity test or self-diagnosed with Ehlers-Danlos and or POTS. Any thoughts on the validity of food sensitivity tests or how to approach suspicion of eating disorders in association with the above mentioned medical diagnosis, either self or medical professionally diagnosed?
That's a great question. And I just really want to validate who mentioned this, because this is what we see a lot. The pathway to develop an eating disorder, there's many pathways, and one of them is sort of down this road of food sensitivities. Kind of in this, even more broadly general, kind of the wellness culture that exists right now. There's the orthorexic sort of ideals, and all of that can make it very easy for a person who genuinely wants to understand their body better and eat healthy. Maybe they want to see if they have any food sensitivities. But we know that if a person starts to kind of restrict the variety of their food, they are much more likely to develop anorexia nervosa just from that behavior alone. And so here at ACUTE, we definitely analyze sensitivities, but more from a sensory perspective. Our dietitians do honor food allergies if it's documented, but otherwise we do stress variety is very important. And I think the way to have that conversation is to approach it from a place of sort of curiosity and non-judgment. I mean, people, again, they're doing the best they can. They're trying to help themselves. Maybe they are worried that they have POTS, or they have been diagnosed with Ehlers-Danlos, and they're worried, what can I do? And so they're trying, I think, from their best place, trying to find ways to help their body feel better. And so kind of open and gentle discussions about, do you find yourself, limiting your food, or are you sort of noticing that you're eating less, or that food has lost an interest for you? Are you worried about that? Are you noticing that? These can be sort of the entry points to helping elicit and bring forth, what the behaviors are, how a person feels. And again, people can just slip into an eating disorder. And so, really, it's perfectly fine to really go there and to ask about it, because an eating disorder is, as we all know, is no one's fault. They never asked for it. And so meeting them with that openness is something that, I think really helps people.
I appreciate the compassion that you shared with that perspective. Thank you. I know we're at time, so I want to be very mindful of that. I did receive a few additional questions that I will send to Renee and get in contact with the individual too that sent it with email, so that we can follow up individually with those questions. But thank you for joining us. Thank you everyone for participating. I appreciate you all greatly. And please be on the lookout for an email for next steps for CEEs, and for also the recording when it will be available. Dr. Cass, thank you so much for your expertise and wisdom, and for joining us today. We really appreciate you.
Thank you, Lydia. Thank you, Renee.
Bye, everyone. Have a great day. Thank you.